Bismillahirrahmanirrahim. Today we are going to cover the segment 2 of developmental abnormalities in bone cell matrix and structure. And in the earlier lecture we have covered the introduction to the bone homeostasis, classification of the bone diseases, and some diseases such as the osteogenesis imperfecta and osteoporosis. Now we will move forward toward the other diseases that are included in this group. These are the references for this lecture. These are the learning objectives for today's lecture. We have almost completely covered the learning objective 1 and 2, and to some extent the learning objective number 3. Now we are going to continue the pathogenesis of different type of bone disorder related to bone cell matrix and structure. By the end of this lecture, you will be able to interpret following clinical scenario. A 60-year-old woman present to your office complaining of aching lower back pain. Upon directed history, she tells you that she feels that she is getting shorter and you note that she is slightly hunched forward. Then a 74-year-old man present to your clinic complaining of bone pain in his left thigh. He also states that his hearing has deteriorated significantly over the last 6 months. Direct questioning revealed that he has noticed an increase in his head size. Then a 5-year-old boy is brought to your office by his parents who are concerned about skeletal deformities. In the first lecture, we have already covered this all these disorders such as the malformation and disease caused by defect in nuclear protein and transcription factor, the diseases caused by defect in hormone and signal transduction mechanism, the diseases that are associated with defect in extracellular structural proteins, and the diseases associated with defects in folding and degradation of the macromolecules. We have also covered the diseases that are associated with defects in metabolic pathways such as osteoporosis. Now, today we will see the diseases associated with decreased bone mass. An important member of this group is osteoporosis. So, this is the way to develop a schema to segregate and divide various disorders of the bone according to their pathogenesis. But when we go to the literature, we see another term, that is metabolic bone disease. The metabolic bone disease is a term that encompasses all the defects of bone synthesis, destruction or reduced bone mineralization, that is isolated or in combination. They result in a structural defect in the skeleton, and these are secondary to some sort of metabolic defect. So all of these are studied under the umbrella of metabolic bone disease. This picture is showing normal bone in which there is lamellar bone, and this lamellar bone is of normal thickness, and the osteocytes are evenly distributed in this lamellar bone. There are numerous fat globules present also and a blood vessel. Whenever we talk about diseases associated with decreased bone mass, there are two terms. One is osteopenia and another is osteoporosis. The osteopenia is simply decreased bone mass, while osteoporosis is the osteopenia that is severely affecting bone to cause fracture or increase the risk of the fracture. The extent of decrease in bone mass is important because in osteopenia, the decrease in bone mass is only 1 to 1.25 of standard deviation from that of normal, and in osteoporosis, thin bone mass uh, decreased, and it is significant enough, and it is 2.5 of standard deviation below mean peak bone mass in young adult. So bone loss is a very important parameter. Now we can say that osteoporosis is a metabolic bone disease in which bone is normally mineralized, but there is decrease in bone mass and bone becomes soft enough that it cannot provide mechanical or structural stability. Now, when we classify the osteoporosis, it can be divided into two, localized type and generalized type. The most common cause of localized type is disused osteoporosis of the limb, while generalized can be divided into primary or secondary. Now, epidemiology of the osteoporosis. The postmenopausal and senile type of osteoporosis are commonest, and these are of generalized type. The most common fracture encountered in osteoporosis are fracture of hip, and common area is neck and intertrochanteric fracture of the femur. The vertebral bodies and distal radius, that is also termed as Colles fracture, comes next. The whites are affected more than black, and this disease is twice frequent in female, and female to male ratio is 2:1 for hip joint, and this ratio increases to 8:1 for vertebral body fracture, and this male female preponderance is nullified in Asian and blacks who are equally affected by osteoporosis. 1 million individuals are affected by this disease each year in United States, which cost about 14 billion US dollar burden on the health budget. About 40 to 50,000 of the osteoporosis patient develop fracture, and looking at these figures, we can conclude that this disease must be on a higher side in other parts of the world, especially in the third world countries, because of dietary problem and nutritional disorders, and these nutritional and dietary disorders are on higher side in this part of the world. Osteoporosis can be divided into primary and secondary type. The primary osteoporosis is more common variety, and it is of uncertain in origin, and principally it occurs in postmenopausal women and elderly people. When it occurs in postmenopausal women, it is termed as type 1, and when it occurs in elderly people, it is termed as type 2. The osteoporosis is labeled as secondary when it is associated with a defined etiology. So this type 1 osteoporosis that affects postmenopausal women is associated with increased osteoclastic activity. Hence, number of remodeling sites in the body are increased. This phenomenon is termed as increased activation frequency. The detailed pathogenesis of all these osteoporosis we will see in later slides. Then what happens in type 2? The type 2 osteoporosis is basically due to osteoblastic functional insufficiency. Here the osteoclast function are normal, and the osteoclast, they lag in synchronizing with their partner. So the osteoblasts are not functioning normally. Osteoclast function are normal, and osteoblasts, they lag in synchronizing with their partner. So it is basically inability of the osteoblast to cope up with the resorption which is done by the osteoclast. So we have seen that this secondary osteoporosis is due to extra osseous disorders, and there are 5 categories of the secondary variety of osteoporosis. These are endocrine disorders, various neoplasia, gastrointestinal or hepatic diseases, drugs, and miscellaneous causes. In now the endocrine disorders, and endocrine disorders include hyperparathyroidism, hyperthyroidism, hypothyroidism, hypogonadism, pituitary tumor, type 1 diabetes, and Addison's disease. In hyperparathyroidism, parathyroid hormone induces osteoclast recruitment and its activity, while hyperthyroidism induces osteoclastic activity and the turnover of the bone is increased. It is, however, associated with limited bone loss. In hypogonadism, in female, it is due to loss of estrogen, and in men, it is due to deficiency of anabolic androgens. Osteoporosis is frequently seen in individuals who have been receiving anti-androgenic therapy for the prostate cancers. Then neoplasia. Neoplasia are also associated with osteoporosis, such as multiple myeloma. The plasma cells are abnormal or malignant in multiple myeloma. So these abnormal or malignant plasma cells secrete osteoclast activating factor. And this osteoclast activating factor is basically responsible for the damage. This osteoporosis is also seen in various leukemia and lymphomas. It is one of the manifestations of squamous cell carcinoma of the lung, in which there is no metastasis to bone, but there is evidence of osteoporosis, and this is attributed to the parathyroid hormone related peptide secretion by the tumor cells. The gastrointestinal and hepatic disease also result in impaired absorption of calcium, phosphate, and vitamin D. And as you know, these are the important constituents of the bone homeostasis. Their deficiency lead to osteoporosis. Then there are some drugs that are also related to osteoporosis. One is anticoagulant, as calcium is a factor of coagulation and some anticoagulants are inhibitor of calcium, and hence it leads to osteoporosis. Then the corticosteroid use is most common cause of osteoporosis, that is iatrogenic. It inhibits osteoblastic activity. So after inhibition of osteoblastic activity, there is disturbed bone formation. The corticosteroid also impair intestinal absorption of calcium, and hence there is increased secretion of parathyroid hormone, which lead to increased osteoclastic activity. Alcohol is a direct inhibitor of osteoclast, and it impairs absorption of and calcium and other dietary constituents from the intestine. Then there are miscellaneous causes of osteoporosis, such as osteogenesis imperfecta, immobilization that results in localized variety of the osteoporosis, and the pulmonary diseases or homocystinuria. We have seen this slide in the previous lecture also, and the peak bone mass is the amount of bony tissue that is present at the end of a skeletal maturation, and it is determined by a lot of factors: the polymorphism in the receptor for vitamin D and LRP56, nutritional status of the person, physical activity, hormonal status, and age. There is a steady decrement in the skeletal mass, that is about 0.7% per year after the age of 40, and this is because of increased osteoclastic activity. As the age advances, there is increased osteoclastic activity and the osteoblastic activity lags behind. So in the upper part of this picture, you can see that the peak bone mass is determined by a variety of factors. Age related and postmenopausal are important ones. Reduced physical activity results in osteoporosis, as we have seen earlier in bone homeostasis. Recall the concept of mechanotransduction. This mechanotransduction is responsible for the bone formation. It is also true for astronauts who develop osteoporosis due to loss of gravitational forces. Hence, biological translation of mechanical forces is impaired. Effect of load magnitude is more, hence weight training exercises increases both the bone mass significantly as compared to the endurance training such as bicycling, in which there is repetition of load. Aging is another cause of osteoporosis. As men get older, their physical activity and movement progressively become limited. So this is another contributing factor for the development of osteoporosis. Another factor is decreased replicative or synthetic activity of the osteoprogenitor cells or osteoblasts respectively. So there is reduction of the activity of matrix bound growth factors. There is a complex mechanism of bone homeostasis regulated by rank ligand, osteoprotegrin, the polymorphism in vitamin D receptor, estrogen receptor, and LRP56. Any mutation in these gene encoding these factors will result in increased osteoclastic activity, hence lead to osteoporosis. The nutritional status contribute to the factor that determine peak bone mass. As we have already seen in the etiology of osteoporosis, that the gastrointestinal and liver diseases result in disturbances in homeostasis, hence lead to osteoporosis. Now the estrogenic influence on osteoporosis. What happens after decade of the menopause? There is loss of 2% of cortical bone and 9% of the cancellous bone each year. And due to this, 40% of postmenopausal women, they develop osteoporosis. Decreased serum concentration of the estrogen will lead to the increased secretion of interleukin 1, interleukin 6 and tumor necrosis factor through mysterious mechanism, and this will result in increased expression of rank and rank ligand. So osteoclasts are invited and stimulated in this area. So osteoporosis is decreased bone amount, but this bone is normal in composition. In both the condition, the postmenopausal and senile osteoporosis, the process is generalized. In postmenopausal women, the mostly affected bone are those having increased surface area, such as cancellous bone compartment of vertebral bodies. The trabecular plate of these vertebral body become perforated, thinned and lose their interconnections. Microfracture occur as a result, and this lead to collapse of the vertebrae. In senile osteoporosis, there is widening of Hawaiian system with thinning of the cortex as a result of subperiosteal and endosteal resorption. In severe cases, cortex looks like cancellous bone, but composition of bone is normal. Though there is presence of discontinuity or gaps within the trabecular bone, the senile osteoporosis showed decreased trabecular thickness, and postmenopausal osteoporosis display discontinuity between the trabeculae. This discontinuity is due to working osteoclast, which lead to perforation and uh, ultimately the fracture. This perforation is of the trabeculae, and then ultimately the fracture occurs. This loss of connectivity or continuity will be exhibited as isolated bone islands on histology. The lower picture is a normal vertebral body. Compare this picture with that of upper picture, which is showing a compression fracture of the vertebral body, and there is characteristic loss of horizontal trabeculae while the vertical trabeculae are thickened. So this is a picture, gross picture of a femoral neck from 82 years old women with osteoporosis, and this gross picture is of same thickness and compared with that of a normal bone. This extreme right picture is showing that this is an osteoporotic bone, and it is very much spongiotic, very much decreased in density as compared to the normal one. On histology, there is loss of connection in bony trabeculae, and these bony trabeculae are also decreased in number and also decreased in size. Histologically, osteoporosis can be of active or inactive type. The active osteoporosis is characterized by accelerated bone turnover, and in this there is increased bone resorption and formation. There is increase in the number of osteoclasts with increased resorptive surface, and increased quantity of osteoid with increased osteoblastic surface. The width of the osteoid seam is normal. In inactive osteoporosis, there is reduced turnover, and there is bone formation that is minimal and decreased resorptive activity. The histologic changes of inactive osteoporosis include decreased number of osteoclasts, decreased resorptive surface, normal or reduced amount of osteoid with decreased osteoblastic activity, and width of the osteoid seam may be normal or decreased. As the disease advances, there is involvement of both the cortex and the medulla, and both of these areas become very much thin, and as it is evident from this picture that there is island of this bony spicule or bony tissue, and the cortex is also very much thin. As far as clinical features are concerned, clinical features of osteoporosis are dependent on the bone which is involved, and these include vertebral fractures. The vertebrae of the thoracic and lumbar region are involved, and these are painful and result in loss of height and can result in various anatomic deformities such as lumbar lordosis, scoliosis, or kyphoscoliosis. When there is fracture of femoral neck, pelvic or spinal area, it leads to immobilization and results in pulmonary embolism and pneumonia. This accounts for 40 to 50,000 deaths per year in USA. The plain radiograph for the diagnosis of osteoporosis are not useful because X-ray cannot reliably detect lesion until significant bone loss, that is about 30 to 40% has already been there. Biopsy for osteoporosis diagnosis is rarely performed these days. DEXA, that is dual energy X-ray absorptiometry, and quantitative computed tomography or QCT measure bone density. Hence, these are useful in the diagnosis of osteoporosis. So, how do we manage osteoporosis? The management is aimed at correction of the factors responsible, which are active player in the bone homeostasis. We correct these by exercise, increased calcium intake, and vitamin D facilitated calcium absorption. With these supplement, bisphosphonate is also used, and they are helpful that reduces osteoclastic activity and induce osteoclastic apoptosis. Denosumab is also used. This is an anti-rank ligand antibody and prevent activation and action of osteoclast. All these measures act on the osteoclast to stop their activity. None has proven so far to act on the osteoblast or bone formation. The hormone replacement therapy or HRT, especially for the postmenopausal variety of the osteoporosis, that is type 1 osteoporosis, was also advocated previously, but it has got some associated complications that are deep venous thrombosis and stroke. So it is not usually recommended. Now coming to the diseases that are caused by osteoclast dysfunction, and an important entity in this group is Paget's disease. This is also termed as Osteitis deformans, and it is a disorder characterized by increased, disordered but structurally unsound bone mass. This abnormal formation of the bone tissue results in a weakened and deformed bone. Though there is increased in the bone mass in total, but as the bone is not formed properly, it is deposited irregularly and not in normal fashion. So it is not going to serve one of its basic function, that is structural support, and it is going to be weak and deformed bone. There are three phases of this Paget's disease. One is initial osteolytic stage, in which there is osteoclastic activity. As a result, there is loss of bone. As both osteoblast and osteoclast work synergetically, what happens in stage 2? There is imbalance among these two types of cell, that is the osteoclast and osteoblast, and there will be lacking of mineralization, which lead to development of jigsaw puzzle or mosaic pattern histologically in the affected area. If you recall your concept from healing from the general pathology, these narrow spaces are filled with collagen, and as collagen is less vascular, and these areas will be less vascularized and filled with collagen. The third stage is also termed as quiescent stage, burnt out stage, or osteosclerotic stage, and it comes years after the initiation of the pathologic process. And due to excessive useless bone formation, it is more compact and more dense. This third stage on radiology exhibit as cotton wool appearance. We will see some of the X-rays in upcoming slide. So we can say that the characteristics of Paget's disease or Osteitis deformans are: it is a disease of osteoclast. The osteoclasts are abnormal in morphology, and they are increased in number. The focal bone involvement is common, and there may be areas of focal areas of increased and disorganized bone turnover. 1% of the population in the United States who have crossed the age of 40 years are affected by this disease. The average of the disease onset is about 70 years. One third of the people with the disease are above the age of 50 years, and the disease is manifested in about 10% of the people over the age of 80 years. It is more common in whites and more common in England, France, Austria, parts of Germany, New Zealand and USA. It is rare in Scandinavians, some Asian populations, China, Japan and Africa. For UK, its prevalence is 2.5% for men, and for female it is about 1.6% in population aged 55 years or more. The incidence and severity of this disease has been decreased in last 25 to 30 years in various areas. Now, etiology of the Paget's disease. The Paget's disease is very much mysterious. Since Paget described this disease in 1877, he labeled it as an inflammatory condition. Then some scientists in 19th century considered that it is a vascular. Then Rebel and Mills, they thought that this has got some viral etiology. Then Rasmussen and Bordier in 1974 proposed a neoplastic theory for this Paget's disease. In early 90s, this Paget's disease was linked with lead toxicity, while in late 90s, some scientists proposed a genetic origin for this disease. The current theory for etiology of Paget's disease includes both the genetic factor and non-genetic factor. It is considered that both these factors are partly responsible for the initiation of this disease. The genetic factors are related with enhanced basal osteoclastogenesis and create a permissive environment for the development of Paget's disease, while the viral infections have been also linked with this Paget's disease. Now, regarding genetic factors, 7 susceptible loci have been identified for the development of Paget's disease of the bone. SQSTM1 gene, that is sequestosome 1 gene, is the most important gene for the adult Paget's disease of the bone. The 15 to 40% of the patient with Paget's disease have at least one affected first degree relative, and 25 to 50% of the patient who have familial disease, and 5 to 15% of the sporadic cases show this characteristic mutation that is present in the exon 7 or 8 of the sequestosome 1 gene. This sequestosome 1 gene is involved in the activation of rank and hence subsequent activation of nuclear factor kappa B, and it causes increased osteoclastic activity and increased susceptibility to the disease. There are some variant that one is called juvenile Paget's disease, and this juvenile Paget's disease is due to activating rank mutation or inactivating osteoprotegrin mutations. Now, the non-genetic factors. The non-genetic factors are thought to play their role because disease show variable penetrance. It is localized to a bone or part of a bone rather than affecting whole skeleton, and incidence and severity of this disease is changing. It is also thought that viruses play some role in the etiology of the Paget's disease, and clue to this etiologic factor come from the presence of viral nuclear protein within the nuclei of osteoclast. Now, pathogenesis of Paget's disease. As you know that this Paget's disease is due to defective osteoclast, and two important etiological factors are the genetic disturbances and viral inclusion within these osteoclasts. So when an osteoclast has got a mutation or mutated or has incorporated a virus in its genome, it is transformed into a giant osteoclast. This giant osteoclast has got more nuclei and it is multinucleated. Normally, the osteoclast has got about 6 to 12 or up to 20 nuclei, but in this mutated giant cell, its number can go up to hundreds. And obviously, we can also see the viral DNA within the osteoclast. Now, these mutated osteoclasts then start liberating various factors, osteoclastic factors. Some are the factors that are responsible for recruitment of osteoblasts, and other are matrix factors. The matrix factors are responsible for angiogenesis and fibrosis, while the osteoblast recruitment factor invite more osteoblasts to this particular milieu. These recruited osteoblasts then further augment the osteoclastogenesis, hence the cycle continues and lead to progression of the disease. So the osteoclast in the Paget's disease have got distinct morphology as well as distinct physiology. They have got viral nuclear inclusions within them, and these are evident by electron microscopy, as is seen in this picture, electron micrograph from the osteoclast. And they have got multiple nuclei, more up to 100 nuclei, and also they are physiologically hypersensitive to osteoclastogenic factors such as vitamin D and rank ligand. As the disease is characterized by various stages, so there is variation in the histology of this disease over time and across various sites. The hallmark of the osteosclerotic phase is mosaic pattern, which is also termed as jigsaw puzzle-like appearance of lamellar bone. Then other phases have less specific features that include osteoclastic activity, and there is presence of numerous resorption pits in the lytic phase. The characteristic morphology of the osteoclast we have discussed many times earlier. So first, there is replacement of marrow adjacent to bone forming surface by loose connective tissue having osteoprogenitor cells and numerous blood vessels. First, woven bone is formed, and then the woven bone ultimately replaced by lamellar bone. As the mosaic pattern predominates, the cellular activity is diminished and periosseous fibrous tissue moves back and normal marrow restores. Finally, the result is coarse, thickened trabeculae and soft porous cortices. These are caricature of the normal bone, and this caricature of normal bone lacks structural support and hence at risk of fracture. This is the gross specimen of a femur that is cut longitudinally, where you can appreciate cortical thickening marked by lower arrow, and the upper arrow is pointing towards coarse trabeculation. The term trabeculae is derived from Latin word trab, that means beams or bars. So these thickened beams or bars are not going to provide structural support to the bone due to various morphological defects we have seen earlier. So now coming to the clinical features of the Paget disease, these clinical features are extremely variable. Mostly the disease is polyostotic, that is 85% of the cases, while 15% of the cases are monoostotic. 80% of the cases of Paget disease are limited to the axial skeleton or proximal femur. Mostly the patient is asymptomatic and disease is diagnosed incidentally. Pain is a presenting feature and it may be result of microfracture or nerve compression. Various deformities have been reported such as Leontitis osseosa and platybasia. The Leontitis fascia is lion-like face and platybasia is invagination of the skull base. Also there is constriction of the posterior fossa. Deformities in the long bones such as tibia or femur are also seen, in which there is anterior bowing of the leg and femur, and due to distortion in the femur head and other deformities, all these lead to secondary osteoarthritis. Fractures are also encountered, and these fractures are of chalk stick type in long bone, while in vertebral body they show compression fracture that result in spinal cord injury or various deformities such as kyphosis. The neurological symptoms are also seen, and one phenomenon is termed as Pagetic steel. It is a condition of lightheadedness that is due to shunting of the blood from the internal carotid system to the bone. As bones are highly vascular in Paget's disease, this highly vascular bone can also lead to high output cardiac failure. Malignant transformation in the pagetoid bone is also reported. This malignant transformation is encountered in 0.7 to 0.9% of the cases. Mostly these malignant transformation lead to osteosarcoma or fibrosarcoma. This malignant transformation increases to 5 to 10% in polyostotic disease. Giant cell tumor, giant cell reparative granuloma, extraosseous hematopoietic masses are also seen. This X-ray is showing the dissolution of the cortex, increased diameter of the diaphysis, and wedge-shaped resorption of the cortex. This resorption of the cortex is forming a flame-like structure within it, and this is termed as flame sign. It is characteristic of early Paget's disease. As the disease advances, it is radiologically characterized by cotton wool appearance. There is presence of cortical disorganization and irregular coarse trabeculation. This X-ray of a spine is showing characteristic picture frame appearance of the lumbar vertebral bodies, and this is due to thickening of the cortices and end plates. So this is the bone deformity in Paget's disease termed as bowing of the leg, and it is frequently associated with fracture as seen in this X-ray. So this is the flame sign, that is wedge-shaped lytic leading edge, and this flame progresses at the rate of about 1 centimeter per year longitudinally. The biochemical markers are available for the diagnosis of Paget's disease. Some are the markers of bone resorption, while others are marker of bone formation. The markers for bone resorption are urinary hydroxyproline serum and telopeptide of type 1 collagen, serum C telopeptide of type 1 collagen, serum deoxypyridinolone cross-links of type 1 collagen, and markers of bone formation are serum alkaline phosphatase, serum bone-specific alkaline phosphatase, osteocalcin, and serum N-terminal propeptide of type 1 collagen. though there is markedly increased alkaline phosphatase, but the calcium and phosphate are within normal limits. If there is no malignant transformation, the disease is not lethal, and it can be managed by giving bisphosphonate and calcitonin that decreases bone turnover. The Gaucher disease is associated with some skeletal manifestations. It is the accumulation of glucosyl ceramide mainly in the macrophage lysosome. It is an autosomal recessive disorder, and beta glucoside gene is located on the long arm of chromosome number 1, and it encodes glucocerebrosidase, that is a lysosomal acid beta glucosidase. It is mutated as single base mutation, and each clinical type of disease exhibit some heterogeneous mutations, and when it is defective or it is decreased, it will result in accumulation of glucosyl ceramide within the cells, especially the macrophages and other cells of the reticuloendothelial system or any other cells in the body. This glucosylceramide is derived from catabolism of membrane of senescent leukocytes that are rich in cerebrosidase, and in the brain they come from the cell membrane of the brain cell that contain gangliosides. The histology of the Gaucher disease is characterized by presence of Gaucher cell that are large cells, and they are about 20 to 100 micron and in size, and they have got eccentric nuclei and clear cytoplasm, and this cytoplasm has got PAS positive material that shows characteristic wrinkled tissue paper appearance. Besides its other manifestation, the Gaucher disease is associated with various skeletal manifestations. One of the skeletal manifestation is failure of remodeling, which is most common, and it is least problematic when compared with other manifestation of this disease. Absent flaring and abnormal phenolization and cylindrization are there, which are necessary for bone modeling and remodeling and lead to elsevier flask deformity of proximal tibia and distal femur. The bone crisis is rare and result from acute infarction of a large bone segment due to interruption of blood flow by the Gaucher cell. Then localized and diffuse bone loss remain asymptomatic unless fracture occur. Another manifestation is osteosclerotic lesion, and it is usually seen in the medullary cavity. Corticomedullary osteonecrosis is usually affects proximal humerus and head of the femur and is the result of compromised blood supply. The pathological fracture is the result of disturbed metabolism uh, uh, within the bone with thinning of the cortex, osteolysis, osteosclerosis, etc. that will lead to spontaneous fracture of the vertebrae, long bone or pelvis. The osteomyelitis and septic arthritis are caused by hematogenous spread of the coliform or anaerobic organisms, and usually it occurs after surgery. Now coming to the diseases that are associated with abnormal mineral homeostasis, there are two diseases in this category that are Rickets and Osteomalacia. Both are characterized by a reduction in bone mineralization. Rickets is a disorder in children in which there is derangement of the bone growth plate and it produces characteristic abnormalities, while osteomalacia occurs in adult in which the bone that is formed during the remodeling process is not properly mineralized. The basic pathogenetic mechanism in these diseases are abnormalities in vitamin D metabolism, phosphate deficiency states, or defects in the process of mineralization. So what are the causes of rickets and osteomalacia? The nutritional deficiencies, gastrointestinal absorption defect, renal tubular defects, and renal osteodystrophy are the major causes that lead to abnormal bone homeostasis and as a result lead to rickets and osteomalacia. The calcium and phosphate are two important minerals that are important in bone homeostasis. The calcium is the 99% of the body calcium is present in the bone, and its main function is the nerve and muscle function, and it is also a member of clotting factors. So clotting is its another function. The plasma calcium remains bound to albumin 50%, while 50% of the plasma calcium is free. The dietary need for the calcium differs according to phase of the life. The adult daily requirement is 750 milligram per day, but the maximum requirement is during breastfeeding, that is about 2 gram per day. This calcium is absorbed in the duodenum by the active transport, while in jejunum it is absorbed through diffusion. 98% of this calcium is reabsorbed in the kidney proximal tubule, and it may be excreted in stool. The phosphate, 85% of the body phosphate is present in the bone, and its major function is uh, function as metabolite. It is an important part that plays its role in energy production, and it is also a member of buffer enzyme system. The plasma phosphate is present mainly in unbound form, and daily requirement of this phosphate is about 1 to 1.5 gram per day. Now, regulation of these two important minerals, the calcium and phosphate, is through the interplay of the important characters such as parathyroid hormone, vitamin D3, and calcitonin. Beside these three important actors, there is involvement of other hormones also, such as estrogen, corticosteroid, thyroid hormones, growth hormones, and various other growth factors. The estrogen, they prevent bone loss, while corticosteroid increases bone loss, as we have seen these two uh, function in the osteoporosis section. Then thyroid hormone lead to osteoporosis, and the growth hormone cause positive calcium balance. This schema is showing the interplay by the major regulatory factors of the calcium and phosphate metabolism. The calcium is absorbed from the intestine. Phosphate is also absorbed from intestine, and the calcium absorption is stimulated by the vitamin D. Then this calcium and phosphate reaches into the extracellular fluid or extracellular space, and the sensors in the body for the calcium alteration or its concentration change are located in the parathyroid gland. This parathyroid gland secretes parathormone. When calcium concentration decreased in the body, this parathyroid hormone releases calcium from the bone. And as we know that calcitonin receptor present on the osteoclast, this calcitonin suppresses calcium release by the bone by suppression of the osteoclast. Vitamin D also releases calcium from bone, and this release is regulated through parathyroid hormone. As the parathyroid hormone also regulates the concentration of alpha-1 hydroxylase that is responsible for the conversion of 25 hydroxycholecalciferol to 125 dihydroxycholecalciferol, and this parathyroid hormone regulated vitamin D also stimulate absorption of calcium from the intestine. This parathyroid hormone increases the reabsorption of calcium and decreases the reabsorption of phosphate from the kidney tubules. The regulation of the production of vitamin D in the kidney is through three mechanisms. When there is hypocalcemia, it induces the release of parathyroid hormone from the parathyroid gland, and this in turn increases alpha-1 hydroxylase activity in the kidney tubule, and this alpha-1 hydroxylase activity will convert the 25 hydroxy vitamin D into 125 dihydroxy vitamin D. This conversion is also facilitated by hypophosphatemia indirectly. When hypophosphatemia increases the alpha-1 hydroxylase activity, and this then increases or regulates the conversion. When there is enough formation of 125 hydroxy vitamin D, this inhibits the activity of alpha-1 hydroxylase. So this alpha-1 hydroxylase is decreased. This is the feedback inhibition of this conversion. The vitamin D reference range is 20 to 100 nanogram per ml, while a person is said to have vitamin D deficiency when its level is less than 20 nanogram per ml. Vitamin D is a contributor of mineralization of the osteoid matrix and epiphyseal cartilage through stimulation of production of osteocalcin by the osteoblast. As we have studied in lecture 1 that there are two types of ossification. One is intramembranous and another is enchondral ossification. In intramembranous ossification, mesenchymal cells directly differentiate into osteoblast and then mineralize, while in enchondral ossification, the growing cartilage at growth plates provisionally mineralized, reabsorbed, and then replaced by osteoid matrix, hence forming bone. In vitamin D deficiency states, the substrate for alpha-1 hydroxylase is decreased. Hence, the vitamin D concentration in the blood is also less. So, the facilitatory role of the vitamin D in absorption of calcium and phosphate from the intestine is reduced. This will lead to decreased serum calcium and phosphate concentration, and this decrease in serum calcium and phosphate concentration is sensed by parathyroid gland, and this parathyroid gland then secretes parathyroid hormone. Due to this parathyroid hormone, there is mobilization of calcium and phosphate from bone on the one hand, while on the other hand, the parathyroid hormone increases the excretion or wastage of phosphate from the kidney tubule. Both these effects will result in decreased product of calcium on phosphate, and this calcium and phosphate product that is decreased will result in poor mineralization of the bone. So in the normal costochondral junction, there is formation of cartilage palisades and orderly transition of the cartilage to the new bone, as we have seen earlier. What happens in the rickets? There is inadequate provisional calcification, failure of the chondrocyte maturation, and apoptosis, which results in overgrowth of the epiphyseal cartilage. These overgrown masses then project into the marrow. The osteoid matrix is deposited in poorly mineralized cartilage remnant. The orderly replacement of the cartilage is disrupted by the deposited matrix and result in expansion of the costochondral junction. Inadequate weak bone hence formed. which undergoes repeated stress and fracture, leading to capillary and fibroblastic overgrowth. All these factors contribute to the bone deformity. The clinical changes in the rickets are due to excess of unmineralized matrix. These changes are dependent on the severity and duration of the process and the individual bone to which stress is applied. These are different for non-ambulatory stage of infancy and ambulatory stage of the infancy. Head and chest are usually affected in non-ambulatory stage of the infancy. The occipital bones are flattened and softened. The parietal bones can be buckled inward by pressure with the release of the pressure. The elastic recoil snaps the bone back into their original position. This condition is also termed as craniotabes. There is frontal boozing and a squared appearance to the head due to excess of osteoid, while the chest shows rachitic rosary and pigeon breast deformity that is due to the weakened metaphyseal area of the rib, and these are subject to the pull of the respiratory muscle and thus they are bent inward and hence they create anterior protrusion of the sternum. During the ambulatory stage of the infancy, deformities usually affect spine, pelvis and tibia. There is lumbar lordosis and bowing of the legs. This picture is showing bowing of the legs due to formation of poorly mineralized bone, and this illustration is summarizing all the clinical features of the rickets, that are craniotabes, rachitic rosary, pigeon chest deformity, Harrison sulcus, then enlarged epiphysis of radius, knocked knees, bow-legged, and lumbar lordosis. The thickening and widening of the physis, that is the growth plate, cupping of the metaphysis, wide metaphysis, bowing of diaphysis, and blurring of the trabeculae are the characteristic radiological finding of rickets. The osteomalacia is characterized by presence of excessive or persistent osteoid, and the contour of the bone is not affected, but these bones, the weak bones, are vulnerable to cross fracture or microfracture, and the important areas are vertebral bodies and femoral neck. The unmineralized osteoid appear as thickened layer of matrix that stains pink in H&E stains and arrange about the more basophilic normally mineralized trabeculae. The clinical features of this osteomalacia are vague bony pains, muscular weakness, fracture following minor trauma, incomplete or greenistic fracture, and looser zones or pseudofracture at weak places in bone. The radiological feature of the osteomalacia, the looser zones are present in the long bone. These are incomplete stress fracture with healing that lack calcium on compression side of the long bone. The vertebrae are the vertebrae in osteomalacia are termed as codfish vertebrae, and this is due to pressure of disc. The pelvis has characteristic X-ray appearance in osteomalacia that is called trefoil pelvis, and this is due to indentation of the acetabular stress fractures. Now the biochemical changes in rickets and osteomalacia. In rickets and osteomalacia, the plasma calcium level is normal or decreased, and the serum phosphate level are also decreased, while the plasma alkaline phosphatase are increased due to osteoblastic activity. The calcium phosphate product is an important clinical parameter, that is the multiplication product of serum calcium and serum phosphate. Normal value of this is 30. In rickets and osteomalacia, it is less than 24. Hyperparathyroidism result in bone resorption. It is termed primary when resulted from autonomous hyperplasia or adenoma, or termed secondary to prolonged state of hypocalcemia. It results in three interrelated morphologies that are osteoporosis, brown tumor, and osteitis fibrosa cystica. The osteoporosis is generalized and affects cortical bone more than the cancellous bone. Subperiosteal and endosteal resorption produces thin cortices and loss of lamina dura around teeth. The osteoclasts tunnel into and dissect centrally along the length of the trabeculae, leaving adjacent marrow spaces to be replaced by fibrovascular tissue. That produces dissecting osteitis, termed as railroad track. Radiologically, the bone mass is decreased with diffuse granularity and the outer cortex is indistinct. Now another morphology is brown tumor. When there is bone loss, it will result in microfracture and secondary hemorrhages, and with the hemorrhage there is influx of macrophages and there is formation of reparative fibrous tissue, and as a result there is increased vascularity, hemorrhage and hemocytin deposition that is seen in this area. Cystic generation is also common in these brown tumors. So due to this gross picture, morphologic picture, it is termed as brown tumor, while the severe form of this disease is termed as osteitis fibrosa cystica, that is also named as von Recklinghausen disease of the bone or severe hyperparathyroidism. It has the combined picture of increased bone cell activity, peritrabecular fibrosis, and cystic brown tumors. This radiograph of the hands is showing bulbous swelling of the hand, small bones of the hand, along with cavity formation, and these are giving clue to the bone resorption. The clinical features of the hyperparathyroidism are described as stones, bones, moans, and groans. The term is stones stand for the kidney stones, bone are skeletal changes, moans are the psychiatric symptoms such as depression, and groans are GI irregularities. Uh, and both these, the moans and groans, are due to increased serum calcium concentrations. And the treatment for this hyperparathyroidism, when it is due to adenoma, there is excision of the parathyroid adenoma, and if it is due to hyperfunctioning hyperplasia of the parathyroid gland, three and half of this parathyroid gland are removed and only half of the parathyroid is left, and that is enough to provide the parathyroid hormone for normal functioning. The renal osteodystrophy are the changes in the bone, morphological changes in the bone that are associated with chronic renal diseases, and these includes all the changes that are associated with dialysis. These renal osteodystrophy manifest themselves as decreased bone mass, that is osteopenia or osteoporosis, impaired mineralization of the bone, that is osteomalacia, secondary hyperparathyroidism, or growth retardation. The histological bone changes in this end stage renal disease can be of three types: high turnover osteodystrophy, low turnover or adynamic bone disease, or the mixed pattern disease. The high turnover osteodystrophy has got increased bone resorption and bone formation, with the increased bone formation that predominate. While in low turnover or aplastic disease, this is adynamic bone, there is little osteoclastic and osteoblastic activity, and less commonly osteomalacia. Then the third pattern is mixed pattern, and in this there are areas of high turnover and low turnover both present. This diagram is showing the pathogenesis of manifestation of chronic renal failure. When there is decreased renal phosphate excretion, it will lead to hyperphosphatemia, and this increased serum phosphate concentration will decrease the serum calcium. This low level of serum calcium will be sensed by parathyroid gland, and parathyroid hormone is secreted. As a result, uh, there is development of osteitis fibrosa cystica and secondary hyperparathyroidism. On the other hand, hyperphosphatemia will uh, decrease renal excretion, or hyperphosphatemia will result in increased product of serum calcium and phosphate, and this figure can go above 70, and this increased product of serum calcium and phosphate will result in metastatic calcification. Metabolic acidosis as a result of this decreased phosphate excretion will result in osteoporosis. Then decreased conversion of cholecalciferol to its active form is decreased. So this will lead to decreased calcium absorption from the intestine, and this is on the one hand, while on the other hand there is aluminum intoxication. This aluminum is coming from the dialysis fluid, and this will lead to development of osteomalacia. This is summary of various bone disorders, and which is showing the comparison of serum calcium, phosphate, alkaline phosphatase, and parathyroid hormone in various conditions. In osteoporosis, the serum calcium and phosphate are unaffected. The alkaline phosphatase is variable, while the parathyroid hormone is unaffected. The disease is characterized by decreased bone mass, while osteoporosis is also uh, show show unaffected calcium and phosphate, but the alkaline phosphatase is increased. Here the parathyroid hormone is also unaffected. So this osteoporosis is characterized by presence of thick dense bone, that is also known as marble bone. The osteomalacia and rickets have got decreased calcium and phosphate, while the alkaline phosphatase is variable and parathyroid hormone is increased, and it results in development of soft bone. Osteitis fibrosa cystica is characterized by increased serum calcium, while the phosphate is decreased. Alkaline phosphatase is also increased, and parathyroid hormone is also increased. Then the Paget's disease of the bone. In this condition, calcium and phosphate are unaffected, and the alkaline phosphatase level depends on the stage of the disease, while the parathyroid hormone is unaffected. So the result is abnormal bone architecture. Now coming to the clinical problems I introduced in the start of this lecture. So you should be able to diagnose this case, the classification and pathogenesis of disease. And the diagnosis is osteoporosis. Now the second case, you should recall its diagnosis, etiology of this disease and pathogenesis of the disease. The diagnosis is Paget's disease of bone. The last case, diagnosis, etiology and mechanism of enchondral ossification of bone, and it is rickets.
Thank you very much for your attention.